My name is Martin Agoje, the President of ISSUP Nigeria Chapter. I welcome you to another session of ISSUP Nigeria Chapter bi-monthly webinar tagged ISSUP Nigeria Knowledge Updates. Today, we shall be looking at a very important topic at this 13th session of ISSUP Nigeria bi-monthly webinar, and the topic is Beyond Dependence, Alcohol-induced Disorders. And the speaker is Dr. Ehigiator Adayonfo. Before I introduce the speaker, let me quickly say that Ehigiator will be joining me to moderate this session. Dr. Ehigiator Adayonfo is an associate professor of substance use and addiction psychiatry in the Department of Mental Health, University of Benin, and an honorary consultant psychiatrist in the addiction unit of the Department of Mental Health, University of Benin Teaching Hospital. He holds a fellowship in psychiatry of the National Postgraduate Medical College of Nigeria, having earlier acquired the degree of Bachelor of Medicine, Bachelor of Surgery from the University of Benin, Benin City, Nigeria. He also has a Postgraduate Diploma in Criminology and Security Studies. His strong desire for specialization in addiction medicine propelled his training and subsequent certification and accreditation as an addiction professional by the National Institute of Mental Health and Neurosciences in India. He has presented papers at several local and international conferences and has not less than 40 publications in local and international journals. He has received numerous awards and recognitions from local and international institutions, both in the area of addiction science, leadership, and as well as in education. He has made modest contributions to clinical care and scientific innovations. For example, in 2020, he co-developed an Android app known as MH1. It screens for common mental illnesses and substance abuse, even remotely, and launched an e-consult facility for the mentally ill and substance use disorder patients in the wake of challenges imposed by the COVID-19 on access to treatment. He is presently the chairman board of the management of Medical Memorial Mental Health and Addiction Rehabilitation Services, and a drug demand reduction professional member of the International Society of Substance Use Prevention and Treatment Professionals, ISSUP. Please join me as I welcome Dr. Adayonfo, and please remember that as he will be speaking, take note of areas we will need clarifications, and please feel free to use the chat box to send your messages that he will respond to after his presentation. So Dr. Adayonfo, welcome, and please go ahead with your presentation.
Thank you very much, Martin, my president, and thank you everybody present for this webinar. The topic is Beyond Dependence, Alcohol-induced Disorders. I'm going to use this outline for this presentation: introduction, relevance of the topic, objectives, alcohol-induced disorders, elucidation and treatment of some alcohol-induced disorders and alcohol use disorder, and I will then make a conclusion and a recommendation. Alcohol is one of the most commonly used substances globally. It is largely illicit, highly cultural, so much so that at every event, marriages, celebrations, and what have you, alcohol is usually present, and it is virtually ubiquitous. It is found everywhere. There are three types: isopropyl alcohol, methyl alcohol, and ethanol, which is the alcohol that we drink. And alcohol may be undistilled and distilled alcohol. The distilled alcohol is the one that has undergone processes beyond just fermentation and the alcohol content can sometimes be as high as 70%. How does alcohol works? Alcohol depresses the central nervous system by enhancing gamma aminobutyric acid in the brain, and this leads to pleasurable sensation. The brain then adapts to this inhibition by increasing glutamic activity, which is an excitatory neurotransmitter. This leads to tolerance, and the implication of this is that more alcohol is needed to be able to cause depression of the central nervous system. Alcohol also causes release of endorphins, which activate opiate receptors, leading to relaxation and euphoria. Alcohol also stimulates the dopaminergic and serotoninergic neurons, particularly in the ventral striatum, which is essentially the brain reward center. In view of the much talked about benefits of alcohol, experts have sat down, and the conclusion is that for one to talk about safe drinking of alcohol, one needs not take something more than 21 units of alcohol per week for a man, and 14 units of alcohol for a week for a woman. And these total units of alcohol must not be taken on less than 5 days in a week. This is because alcohol is said to have some beneficial effects. So those who must drink must not drink beyond these limits per week. To calculate the unit of alcohol in any drink, you multiply the volume of the content in the bottle or whatever it is, the volume in mils of the alcohol by the percentage of alcohol, and you divide by 1,000. Alcohol is metabolized by a competent liver at the rate of 8 grams of pure alcohol, or 1 unit per hour. It is metabolized essentially by 2 enzymes, and acetaldehyde. Alcohol is metabolized to acetaldehyde by alcohol dehydrogenase, and thereafter acetaldehyde is metabolized to acetate by acetaldehyde dehydrogenase. Gamma glutide transferase, which is a liver enzyme, is the most widely used laboratory marker of hazardous alcohol use or alcohol use disorder. And the normal range is 5 to 40 units per liter. So this is a liver enzyme in people that have harmful alcohol use or even hazardous alcohol use. When you do this test for this liver enzyme, the quantity of this enzyme will be more than 40 units per liter. There are many causes for alcohol use problems. One is genetic. It could be psychological, social, and environmental factors may contribute to alcohol use problems. Indeed, the gene ALDH2 504K has been reported to be protective. This presentation will provide, improve, or refresh the knowledge of alcohol use disorder and alcohol-induced disorder, which is necessary for the following reasons. Alcohol is one of the most commonly used substances globally. Abuse of alcohol contributes to more than 200 diseases and injuries. And indeed, people die each year from the harmful use of alcohol. And this to 343 people dying every 1 hour. It is only imperative that professionals involved in the prevention, treatment, and recovery of persons with substance use disorder must be adept in the matter of not only alcohol use disorder, but also alcohol-induced disorders. It is veritable that all healthcare professionals, and indeed the general public, need to know all the sides to alcohol. Consequently, the presentation will draw attention to other disorders caused by alcohol while not neglecting alcohol use disorder. Diagnostic criteria, clinical features, and treatment will also be highlighted. This slide shows a list of the alcohol-induced disorders. And we have here psychotic disorder, for example, delusion of jealousy. We have bipolar disorder, depressive disorder, anxiety disorder, sleep disorder, sexual dysfunctions, delirium, neurocognitive disorders, alcohol intoxication, alcohol withdrawal, and indeed other harmful use of alcohol, which include cardiomyopathy, peptic ulcer disease, liver disease, pancreatic disease, cancers, including breast cancer, acute kidney injury, cerebrovascular accident, and others. I will now look at some selected alcohol-induced disorders and deal with them with in some detail. Number one here is alcohol intoxication. What are the features of alcohol intoxication? There is a recent alcohol use, which is usually in excess of what the person is used to drinking. And the clinical presentation includes slurred speech, ataxic gait, disinhibition, or where the quantity of alcohol is so much, somnolence, and even coma. When you examine the patient, you may smell alcohol on the breath of the patient. And if you have the benefit of the use of a breathalyzer, the alcohol content will be in excess of 0.08%. The extremities will be warm, there will be red eyes, there will be increased pulse rates, and the systolic blood pressure will be above normal. And what is the treatment of this condition? One, the patient is put on NIM per oral because they are at risk of vomiting and aspirating their vomitors. They are not in left lateral position. We give IV fluid, and the IV fluid of choice will be normal saline. But if you have done a blood sugar and it is showing hypoglycemia, then you may give dextrose only after giving thiamine supplementation at 100 milligram IV. The patient is put on antipeptic ulcer medicine because alcohol is corrosive to the intestine and even the stomach. They are put on antiemetic because they have a tendency to vomit. You don't want them to vomit. And then if they are agitated, the medication of choice is usually haloperidol at 2.5 to 5 milligram IM or intramuscularly or intravenously. There is a medicine called metadosine. This helps to speed up the metabolism of alcohol, and it may be given at a dose of 300 milligram IV. Sometimes hemodialysis may be indicated if the blood alcohol concentration of the individual is greater than 130 millimole per liter. However, while the level of alcohol in the blood drops, one is expected to watch out for withdrawal symptoms. The second one is alcohol withdrawal syndrome. This can follow cessation or reduction of regular heavy alcohol use. It develops 4 to 6 hours after such cessation or reduction of regular heavy alcohol use, and it may persist for 10 to 14 days. The symptoms may be uncomplicated withdrawal or complicated withdrawal. The features of uncomplicated withdrawal include tachycardia, hypertension, sweating, tremors, insomnia, nausea, vomiting, psychomotor agitation, and anxiety. Where it is complicated withdrawal, there may be hallucinosis, hallucinations, seizures, and delirium tremors. Alcohol withdrawal syndrome is usually monitored by using the Clinical Institute Withdrawal Assessment, alcohol reversed scale. What's the treatment for alcohol withdrawal syndrome? The mainstay of the treatment is the use of benzodiazepines. The long-acting benzodiazepines are preferred in most cases since they are able to achieve a smooth control of withdrawal symptoms. However, short-acting benzodiazepines like the lorazepam are preferred in the elderly and in patients who have hepatic or respiratory dysfunction. There are 3 strategies for delivering the benzodiazepines. First one is the fixed dose regimen, and then we have the front-loading regimen, and we also have the symptom-triggered regimen. For the fixed dose regimen, what we do is to give 5 milligrams of diazepam, which is equivalent to 1 milligram of lorazepam for each unit of alcohol consumed by the patient per day, to a maximum of 60 milligrams of diazepam or 12 milligrams of lorazepam per day. This total daily dose is given in 3 or 4 divided doses, and it is tapered over 7 to 10 days. We usually will taper the day dose first before we do same with the night doses. This is usually the preferred strategy for giving benzodiazepine if you are dealing with alcohol withdrawal syndrome in outpatient setting. Then we have the front-loading regimen for delivering the benzodiazepine. Here, we give 20 milligrams of diazepam every 2 hours until the withdrawal symptoms or signs abate. This may be used for mild alcohol dependence. In cases where the patient has a competent hepatic function, or when there is absence of history of complicated withdrawal. The last or the third strategy for delivering benzodiazepine for alcohol withdrawal syndrome is the symptom-triggered regimen. Here, the quantity of benzodiazepine you will give the patient is based on the Clinical Institute Withdrawal Assessment alcohol reserve score of the patient. The score is determined every 1 hour if withdrawal is severe. That means if the patient has hallucination or seizure, or even in delirium tremors, you will need to administer or check for the CIWA score of the patient every 1 hour, or you do it every 4 to 6 hours for mild to moderate withdrawal syndrome. If the score is greater than 10, you give 10 milligrams of diazepam. Understandably, since there's need to monitor the withdrawal symptom using this instrument, this method can only be used in inpatient setting. In practice, we usually combine symptom-triggered strategy with the fixed dose regimen. Alcohol withdrawal seizure, another alcohol-induced disorder. This commonly happens 1 day to 2 days after cessation or reduction of alcohol use. The seizure is generalized, tonic, clonic, and there are other signs of withdrawal symptoms, as already shown in the previous slide. The treatment of the alcohol withdrawal seizure is to give diazepam 10 milligram or lorazepam 2 milligram intravenously every 10 to 15 minutes until the seizure abates. And thereafter, we revert to the symptom-triggered approach that was talked about in the previous slide. And then we need to also watch out for delirium tremens. Alcohol withdrawal delirium. This commonly happens 48 to 72 hours after cessation or reduction of alcohol use. Delirium describes a global deterioration in cognitive function coupled with confusion or alteration in consciousness. The characteristics of alcohol withdrawal delirium includes that the delirium is hyperactive. There is autonomic and then you have visual